a question, please. Here is a question I want to put to Joel Allison and Dr. Crow. And the question says this: if we insure 47, 48 million additional Americans, but we don't add any doctors and we don't add any new hospitals, doesn't that mean rationing? And this questioner goes on to say, if there is rationing, won't seniors be at the greatest risk in such a system?
As I said when I spoke earlier, just because you have coverage does not give you access to care. And we do have a shortage of physicians and nurses in this country today. We have an aging population. I being one of those boomers aging out, I am concerned that we do not have an adequate professional staff to care for all the people who need access to care. And again, you can be covered by Medicare and still not be able to see a physician or have long delays. Having long delays and not being able to see a physician is what I can refer to as implicit rationing, not explicit as you have in other countries. And unfortunately, I would never want to see that explicit. I would never, unfortunately, I hope that we as a country will always make sure that we are taking care of our citizens and doing it in the right way. And the concern that I have, again, as we look at providing this coverage, is how will they access providers and how will they be able to see physicians in a timely manner, both primary care and specialty. That's why the management of chronic diseases and the medical homes, the accountable care organizations, and the alignment with physicians and hospitals, I truly believe offers the greatest opportunity, because you would be providing care for a defined population, you would be using physician extenders, and you would hopefully be able to reduce the number of hospitalizations because you've had good prevention and wellness. And I think that's the future of health care in America.
Certainly the uninsured number is a problem. We have a perfect storm also with an aging population, so it's more than that. And you know, sitting here as a primary care physician, I know very well how there's not enough of us now, and there's certainly not going to be enough of us in 10 years. I mean, there's studies that say that we need close to 30,000 more primary care physicians in this country 10 years from now, and we have no pipeline. About 2% of all medical students are becoming what I am right now. That's a real problem. In 10 years. So what are we doing about it now is we got to take care of the people that are here. So you work a little bit harder, you invest in medical homes, hopefully, where you are using a team approach. With today's technology, you can be virtual a lot more often. You can do things not only at patient visits, but episodically through online care. And that's the only way. The only way we can take care of the population that's going to need to be taken care of in the next 10 years is with the workforce we have. But something we have to look at in healthcare reform is not only where we are today, but 10 years from now, 20 years from now, what does the physician workforce look like, and what do we need to take care of those people, and start thinking about that now all the way back into medical schools and graduate medical education.
Dr. Goodman, I want to put on one of my other hats, and that's the hat of a county judge who has a public hospital, has a county hospital in their county. And what we have heard thus far as we begin to try to filter through this is that part of the way that that's going to be paid for is taking what was referred to earlier as the DISPRO money and use that to pay for the cost of the insurance. If that happens, then the hospitals like John Peter Smith in Tarrant County, Parkland in Dallas County will close, because the county taxpayers cannot afford that burden in the form of property taxes to keep that hospital open. When those hospitals close, so close the teaching institutes. John Peter Smith is the largest family practice physician residency program in the country. So you talk about shortages of physicians. When you close down the public hospitals, you're going to close down most of the teaching institutions where your residents, where your doctors are coming from. So as you go through this process, it's very important to remember that when they attempt to take that DISPRO money to pay for this uninsured cost, you're in effect fixing to really create a problem not only in those folks who are that safety net hospital, they're going to be pouring into to Baylor and THR and other hospitals in this area. The teaching facilities are going to go away.
Let me just ask a quick follow-up question. Is it just my impression, or is it the reality, that the American Medical Association, American Hospital Association, and other groups that ought to know a lot about these issues have been very, very silent on the problems that we're going to face?
I speak to the AHA, and I've not always agreed with the AHA, I must say.
The AHA is the
American Hospital Association, because, again, it's a large national organization, and they're not able to really understand the uniqueness and the fact that healthcare is still local. And they try to represent too broad a group of individuals, and there's differences from every state. And again, you have to look at what happens in your own state, in your own community, and that's why I believe you still have to have representation locally about what you're going to do on healthcare reform. AHA has been silent on some of the things that I wish they would be more vocal, and they've been too vocal on some things I wish they'd be a little more silent.
One of the things I'll say from the county's perspective is that we need to be at the table, just as these gentlemen need to be at the table. And right now, the reason why I think a lot of folks are silent is because we don't know what's out there. We like y'all, have not seen a bill that we can read and see what happens, what it means to us on a local level, where the rubber really meets the road, where we've got to get out and take care of that kid.
So are you telling us that all these interest groups that are meeting behind closed doors and negotiating, that they don't feel free to come out and publicly discuss these issues because then they'll be kicked away from the table? Is that what you're saying?
That's true.
I don't know the reason. All I know is that we have not had an opportunity to really understand, because we don't have anything to read.
Yeah, you do. Get the
my congressman is Michael Burgess, Dr. Michael Burgess. And when it comes to someone who would understand health care, I would say he'd be one of the top ones in that area. I know he's worked with Congressman Barton on his committee. You know, it's one of those things where you need to be able to read what the bill is going to be before you vote on it. And I don't think
Let's go back to the congressman. If there's a public plan, should members of Congress and federal employees have to be in that plan?
Well, if there's a public plan in a free society that we vote for, the answer to that is yes.
Another question, let me just paraphrase it this way. When the Republicans had the White House and the Senate and the House, you guys didn't really deal with a lot of these problems. Hate to put it that way, but if you had, maybe we wouldn't be here tonight.
I'm going to crack at that. We passed Medicare Part D prescription drug benefit that 95% of senior citizens have chosen voluntarily to accept. We passed medical malpractice through the Republican House of Representatives, 3 straight Congresses. It died in the Senate because of the 60-vote cloture rule. We passed a bill out of my committee that says if insurance is offered in any state, it can be offered in every state. That bill wasn't able to get to the House floor because of the Democratic resistance to it. I could go on and on. We did pass and become law National Institute of Health Reform, Federal Drug Administration Reform, numerous bills